Thank you very much for joining us. And we're going to have an exciting time today. So today we are studying red eye. Red eye. Okay? Red eye. And I'm sharing the presentation, red eye. So you realize that red eye is very common. And the reason why it can be missed is because there are some common causes which are usually benign. Okay? And then there are also some causes of red eye which can be very detrimental, and if we don't even take care, can lead to blindness and in some cases death. Okay, so for those who are joining us on TikTok, please, we are also streaming it on YouTube where we have actual PowerPoint slides. Okay, I don't know how to share it on TikTok, so if you want to join us on YouTube, you can just join us on MedCognito YouTube, MedCognito Live. Okay, so I'm just letting you know that we are doing red eye today. And so if you look at the presentation very well, it says that eye redness is a very common issue, okay? And many of the common causes are relatively benign. In other words, they don't really cause a lot of trouble, but some can lead to significant vision loss and require urgent referral. So that's something you have to know that, okay, which patients am I going to refer to a specialist? Which patients am I going to just manage in my office as a doctor, right? So what are the causal conditions of red eye? What are the things which cause red eye? And the list is not exhaustive, so I'm just going to list some of them. So there are causes of red eye which affect, the eyelid itself. All right, it affects the eyelid. I'm just getting some water. There are some causes of red eye which affects the eyelid itself. Some also affect the eyelashes. Some also affect the orbit of the eye. Okay, some affect the orbit of the eye, and then some affect the conjunctiva. Some affect the sclera of the eye itself. Some also affect the cornea and the anterior chamber and the iris and the trauma, and some also caused by trauma. So you have to know, what is causing this particular red eye. So my friends on TikTok, as I said, this is the first time we are doing a TikTok live, and we're also loading it on YouTube as well. And on the YouTube, you realize that you see the PowerPoint presentation. So you can join us on YouTube so you can take advantage of that to see the presentation I'm speaking from. Okay, so that is it. And you can also share the link to as many friends as possible. Now, there are some objectives you have to know if you are preparing for an exam or if you are planning on taking care of patients with red eye. Okay, so the objective is that when you have a patient with red eye, you must be able to diagnose the cause of the red eye, the severity of the red eye, the complications of red eye, and you must also initiate an appropriate management plan. And in particular, you must know when you are going to refer patients with red eye. Because for many of us, oh, this is red eye, let's get some antibiotics. No, but there are some causes, there are some things which can really, really be detrimental. Okay, so you want to pay attention. You want to pay attention to that. So I'm just continuing the presentation. And you must know, when am I going to get an ophthalmologist involved and when am I not going to get an ophthalmologist involved? Okay, so if you have a patient with red eye or eye redness, you must be able to list the critical clinical findings and those which are based on information gathered on history and physical exam. Okay, and you must be able to differentiate the various causes of red eye. Say, look, is this red eye benign or is this red eye serious that I need to pay attention to? Number two, you must be able to determine whether in this particular red eye, the patient with this particular red eye, the visual acuity is affected or not. Okay, now I'm dealing with this topic because a lot of us as healthcare providers, when it comes to eye cases, go like, hey, I don't know what to do. I don't know what to do. So that is why we are dealing with this particular topic today. Now, you must also list and interpret critical investigations, including a slit lamp examination and fluorescein administration and intraocular measurement as appropriate, and construct an effective initial management plan, including determining if the patient requires urgent referral. And today's class, what I'm going to do is that I'm not going to lead with questions. Rather, I'm going to take my time and teach the concept very, very well. Okay, teach the concept. And it's after the concept has been taught, then I will give you some questions to try. So before we get into the deep dive into this, those on TikTok, again, if you want to see, okay, if you want to see the presentation itself, we are hosting it on YouTube. And on YouTube, it is at MedCognito. MedCognito is spelled as MED. MED, MedCognito, MEDCOGNITO. Okay, MedCognito. So if you want to join us and see the PowerPoint presentation, join us on YouTube right now. Okay. And for those who are joined on YouTube, you realize that we are trying our best to present it on TikTok as well. So we don't know. This is our first time, so please forgive me. Okay. Yeah. All right. Okay. So let's go. What are the causes of eye redness from the various parts of the eye? Number one, you have to know that eye redness can come from the various parts of the eye. The first part can be the eyelid, the orbit itself, or the lacrimal system. The lacrimal system is, where the tears flow. Okay. So you can have what you call a hodioleum. You can also have what you call a chalazion. There can also be blepharitis. That is inflammation of the eyelid itself. We also have what you call entropion and ectropion. And I'll take my time in the coming days and weeks, to teach all these concepts. Okay. And then the person can also develop red eye because there's a foreign body on the eye, or there's been a laceration. And then we also have what you call dacrocystitis and dacroadenitis, right? Good. Then when you go to the conjunctiva itself, the white part of the eye that we see, you can have people who have bleeding into the conjunctiva. So we call that conjunctival hemorrhage. We also have conjunctivitis, which is the common one that many of us see, right? And then we also have dry eyes. So you can have some people whose eyes are so dry that they develop red eye. And then you can also have what you call a pterygium. And I think in a future class, what I will do is I will show pictures of all these conditions so you can be able to pick them up very well. And then we also have what we call scleritis and episcleritis. All right, good. And then we also have preseptal and orbital cellulitis. So these are all causes of red eye based on the conjunctiva and the sclera. Now, when you go to the cornea of the eye, so we are looking at various parts of the eye and what causes red eye from them. We also have foreign body. So you can have somebody who has a contact lens which lands on the eye or which is causing some problems. And then keratitis and abrasion. So corneal abrasion. Many of us hear that a lot. And then there can also be a corneal laceration. And then there can also be a corneal ulcer as well. Okay, so these are all causes of red eye that we need to know. And then the eye also has what we call the anterior chamber and the posterior chamber. So the anterior chamber, we have anterior uveitis. Okay, we also have acute glaucoma. We also have hyphema, which is when you have blood in the anterior chamber. And then we also have hypopion. Now, what's the difference between hyphema and hypopion? Hyphema basically is blood in the anterior chamber. Hyphema, okay? And then hypopion, rather, is pus in the anterior chamber. So don't confuse the two. We have hyphema and we also have hypopion. But both of these can cause red eye. Doctors and everyone join us, those on TikTok and those on YouTube and Facebook. If you have understood it up to this point, I just want you to type yes, yes, yes. I want to see that we are interacting so that I will know, whether I should slow down or go back a little bit. We are looking at various causes of red eye. Various causes of red eye. So those on TikTok, those on YouTube, just type yes if you are following. Beautiful. So I'm getting a lot of yeses on YouTube. Someone says, you are an excellent teacher. Thank you very much. So those on TikTok as well, if you can hear me and you are following, just type yes, yes, yes. Okay, good. Now, let's go to causes of red eye. Other causes can be trauma, okay? And we can also have post-operative endophthalmitis. So somebody has had surgery to the eye, and then there can be infection there. And then it could also be, somebody who just got some medication applied to the eye. And kinds of medications can be prostaglandin analogs, all right? So today's class, I just want us to focus on a particular condition called acute angle closure glaucoma. So there are various causes of red eye, but today I want us to deal with one which can cause blindness right there and then if it is not managed properly. And the name of the condition is acute angle closure glaucoma. Acute angle closure glaucoma. Again, those on TikTok, if you want to see the presentation, just go to YouTube, okay? Go to YouTube, just type MedCognito. MedCognito, MEDCOGNITO, and you will see the actual PowerPoint presentation and everything. It is streaming live on YouTube. Okay, so now let's dive into acute angle closure glaucoma. There's been a general traditional perspective that glaucoma is just as a result of increased intraocular pressure. When I say increased intraocular pressure, what do I mean? I mean, many of us just believe that glaucoma is as a result of increase in the pressure of the eye, right? Yes. But then a more accurate definition of glaucoma is that it is an optic neuropathy. It's an optic neuropathy, okay? And it may not always be associated with increased intraocular pressure. It is not all the time that there's increased intraocular pressure. But the general knowledge that a lot of people know about is that glaucoma is as a result of increased intraocular pressure. But the very good definition is that it is an optic neuropathy. Okay, it's an optic neuropathy, and it may not always be associated with increased intraocular pressure. Okay, good. So for us to appreciate this very well, I'm going to take you through the flow of the tear, like when you produce tears, okay? When you produce aqueous humor, the flow, because if you understand the flow very well, then you can understand acute angle closure glaucoma very well, okay? So aqueous humor is produced by what we call the ciliary process. And if you look at the presentation very well, okay, if you look at the presentation very well, the ciliary process is what is down there. Now, when it produces what we call the aqueous humor, it has to flow between the lens of the eye, okay, so the lens is that transparent part which allows a light to go to the back of the eye. So it has to travel between the lens and the iris. So if you see the iris is that thing which is protruding downwards, okay? And the space between the iris is what we call the pupil. I'm taking my time to teach this because ophthalmology and the issues around it is not something a lot of people are very conversant with, right? So remember, we have the ciliary process, we have the lens, we have the iris. Now, in between the iris, so just think about the iris this way. The hole there is what we call the pupil. So when aqueous humor is produced, it has to go between the lens and the iris, and then it has to flow through the pupil and then go into the what we call the canal of sclem. Okay, so just think about it. Assuming something is putting the lens close to the iris, what will happen is that then the fluid is going to build up there. Basically, then the fluid is going to build up there, and there can be a big problem. Okay, so please let me pause here. For those who want to see what I'm illustrating, you can see it live on YouTube. Secondly, those on YouTube already, I want to know, before we move on, have you understood the flow of aqueous humor from the ciliary body to the drainage system? Please, have you understood it? If you've understood it, just type understood. Understood. If you've understood it, just type understood. Understood. I want to see it. And those on TikTok as well. If you've understood it, just type understood. Don't type yes. Type understood so that I'll know that you've understood it, because this is very important. Okay. This is very, 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 very important. So I've shared the picture again. I've made it big. Okay. So that you can be able to appreciate it very well. So aqueous humor is produced from the ciliary process. It goes between the lens and the iris. It flows through the space between in the iris, which is what we call the pupil, and then it drains. It drains. This is it. This is it. If you get this right, you've gotten the whole concept of acute angle closure glaucoma very well. So you realize that if there's a blockage can occur anywhere, right? Assuming the drainage is not enough, there can be accumulation of excessive aqueous humor. That's number one. Number two, assuming the path of the fluid is also decreased, there's also a problem. So acute angle closure glaucoma can occur in various places, right? Or it can occur as a result of various things. Either too much aqueous humor is being produced, or the aqueous humor you are producing is not being drained well, or the path of the aqueous humor is being blocked. That's a problem. Okay, awesome. So what should give you a clue about acute angle closure glaucoma? What should be the clue? In fact, somebody just put something here. It says, first time to know that glaucoma is an optic neuropathy. Yes. So you realize that most of the time, what people say is, glaucoma is as a result of increased intraocular pressure. Yes. But then the basic thing is that it's an optic neuropathy, right? It's an optic neuropathy. Okay. So the lens or the peripheral iris can block the trabecular meshwork. That's number one. And this leads to obstruction of the outflow of the aqueous humor, which we talked about. And usually this is common in people who have a shallow anterior chamber. So let me go back. Let me go back to the picture. It can happen in people who have, a shallow anterior chamber. A shallow anterior chamber. And that is what can lead to some of these big problems. Okay. And as well, in the exam, in your board exam, whether as a medical doctor for the MCQE1, USMLE, or whatever, all the time, think about this. An acute angle closure glaucoma attack is usually as a result of dilatation of the pupils. Okay, dilatation of the pupils. And I'm going to explain what is going on there. It can be, most of the time, it's as a result of dilatation of the pupil. So the pupil is the space between the iris, which is the stick-like thing up there, and the stick-like thing down here. Okay. And in most cases, an acute attack is usually precipitated by pupillary dilatation. Okay, let's go to the next slide. What are the risk factors? I want you to write this in your book. And those joining us on TikTok and YouTube, please type it in the comment section as well. The first risk factor that you need to know is that most of the people who are affected by acute angle closure glaucoma, they are more than 60 years. Please, you are preparing for a board exam, okay? Most of the people who are affected by acute angle closure glaucoma, they are more than 60 years. Write it in your book. Write it in your book. And then after that, you can send me a WhatsApp on the notes you are taking at +1 306 891 5649. +1 306 891 5649. That's my WhatsApp number. Okay. So if you want to reach me, you have any question, you can just type it +1 306 891 5649. So that's the first risk factor. Age of more than 60 years. Next risk factor is the race of the patient. Asian patient or a native North American. Okay. Asian patient or a native North American. And then the third risk factor for acute angle closure glaucoma is a female. So we've talked about 3 risk factors here. Number 1, age more than 60 years. Number 2, the race of the patient, Asian, Native North American. And number 3, a female. Okay, number 3, a female. So 60 years, race, female. Let's move on. So you must master the causes of pupillary dilatation that can lead to an acute angle closure glaucoma. You must master this. So please, for your board exam, I need you to write this down. You must master this information. And for those who want to see the presentation on TikTok, please, you can see the presentation on our YouTube. Okay, live YouTube, MedCognito, MEDCOGNITO. MEDCOGNITO. So you must master the causes of pupillary dilatation. So what are the causes? Number 1, and in your board exam, these are the things you need to look out for. You will either have to be given a clue that the patient used a topical medication, a parasympathetic agent, like a mydriatic or an antihistamine. That's the first thing. Number 2, it could also be that the patient took a sympathomimetic agent like epinephrine or pseudoephedrine. Number 3, another clue which should lead you to think about acute angle closure glaucoma is a dim room. A dim room. A dim room. Okay, so one place you have to really think about is that patient who was at the movie theater. Okay, the movie theater, you know that the movie theater, the place is very dark, right? And maybe at times before the movie starts, then there's a problem. So a dim room. And then the patient can also develop acute angle closure glaucoma in a context of the patient is emotionally upset, angry. The patient is angry, emotionally upset. So please know these things, because if you see them in your board exam, it should be able to trigger in your mind. Okay, I realized that Dr. Boni was teaching this on TikTok and on YouTube and on Facebook, that these are the causes of pupillary dilatation. So first, topical or systemic parasympatholytic agents. So if a patient takes antihistamine, the patient takes a mydriatic, these can lead to it. Number 2, if a patient takes epinephrine or pseudoephedrine for whatever reason. Number 3, if the place has dim illumination. Why? Because if you are in a place with dim illumination, your pupils want to dilate, right? Your pupils want to open up. And we learned that in many cases of acute angle closure glaucoma, right, there is a concern with pupillary dilatation. And then if somebody also gets upset, the person is angry, that can also lead to, the anterior chamber becoming shallow, and that can be a problem. There can also be other causes, like if you have a patient who uses cocaine, sniffs cocaine. If the patient sniffs cocaine, that can be a problem. Okay, and if you have a patient who uses nebulized beta sympathomimetic or anticholinergic medications like albuterol or Ventolin or ipratropium bromide, these can also lead to pupillary dilatation, which can precipitate, which can precipitate acute angle closure glaucoma. Please, I want to pause here. Are we all tracking together? Please, are we all tracking together? Are we all tracking together? Those on TikTok, those on YouTube, are we all tracking together? If we are tracking together, please type yes. Yes, yes. If we are tracking together, yes, yes. Because these clues I've given you, this is what will help you to pick up, okay, a patient has sudden vision loss with redness of the eye. What in the question stem is pointing to acute angle closure glaucoma? What in the question stem is pointing to acute angle closure glaucoma? Maybe the patient was at a movie. Maybe the patient got upset. Maybe the patient used an antihistamine. Yes. These are the things I want you to start paying attention to. Okay? All right. Now, how will a patient with acute angle closure glaucoma present? How will the patient present? So think about it. The patient was at a movie theater. As the movie was about to start, the patient started complaining of severe pain. So you realize that acute angle closure glaucoma, it starts abruptly. It starts all of a sudden. So that's the first thing you want to write in your book. It starts all of a sudden. Number two, it causes pain, a lot of pain. Number three, you realize that the patient will say that I can't see properly. I can't see properly. So there's severe visual impairment if you don't treat it quickly. And then there can also be frontal or supraorbital headache. So the patient is having a lot of headache. So just think about it. 60-year-old female who is an Asian who was taken to the movie theater by her son or daughter. And as soon as the movie was about to start and the place became dim, the patient starts complaining of severe eye pain. Started suddenly. And the patient says, I can't see properly. And because of that, now I even have a headache. And my vision is blurry, blurred vision. And now the patient says, look, I have nausea. I need to vomit. Please, can you get me some gravel? I need to vomit. In some unique cases, it may not cause pain, but for a board exam situation, think about it. Movie theater, elderly person above 60, Asian, place is dark, all of a sudden, abrupt pain, painful eye, severe visual impairment, visual blurring, complaint of nausea, acute angle closure glaucoma. Acute angle closure glaucoma. What I want you to understand is that, as a doctor in training or somebody who is preparing for the MCQA1 or AMC or USMLE, what you have to understand is that this is an ocular emergency. It's an eye emergency. And so you cannot miss it. That is why I'm taking my time. That's why I'm taking my time. So those on TikTok, you can just give us a like. Those on YouTube as well, please click on the like and the subscribe button. So whenever we go live every Sunday, you can be able to join us. All right. So remember, acute angle closure glaucoma is an emergency. And that is why if you cannot be able to pick it up in a board exam, that is not good. That is not good. That means you are not safe, right? At least you must be able to pick it up and even call for help. Okay, good. So, what about a physical exam? Physical exam. How will a patient with acute angle closure glaucoma present on physical exam? For those on TikTok, if you want to see the images we are showing, just go to YouTube. Just type MedCognito, MEDCOGNITO. You'll see it there. Okay. So physical exam features of a patient with acute angle closure glaucoma. Number one, you realize that the patient's eye will be described as fixed. It will be fixed. Fixed. It will be said it will be fixed. And then you'll also see a mid-position pupil. So the pupil is not too large. It is not too small. Mid-position pupil. It is fixed. Number two, there is a hazy cornea. So look at what is happening there. If you look at a picture I'm showing very well, it looks like there's a cloud around the pupil. And then there's conjunctival injection. So you see that the conjunctiva looks red. That's why we call red eye. And then if you touch the eye, the eye is hard like a rock. The eye is hard like a rock. The eye is hard. So doctors, please, are we picking it up? 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 I really want us to pick everything up. Dr. Dogowa says, excellent teaching. Doc, this is what I live for. I'm a teacher. I love to teach. Okay. So those on TikTok, if you want to see the presentation, come to YouTube. You'll see the presentation itself. Okay. So please think about this. Let me recap again because ophthalmology is a lot of people's weakness. Number one, risk factors: age more than 60 years, Asian, female, or Native American. 4 risk factors, right? 4 risk factors: age more than 60 years, female, Native American, or Asian. What happened? The patient either took an antihistamine, or the common thing you need to know is maybe the patient went to a movie theater. The place became dark. What happened? The patient's pupils started dilating. And because of that, it started blocking the aqueous humor flow. The patient will say, I have a headache. I can't see properly. Okay, I have nausea. Someone will say, what's the relation between eye pain and nausea? Acute angle closure glaucoma. I have nausea. I want to vomit. Then when you touch the eye, boom, the eye is very, very hard. There's a problem. Acute angle closure glaucoma. It's an emergency. You need to know what to do for the patient. Okay, so now that we've talked about all these, assuming you are in your emergency room and someone brings you this, okay, someone brings you this case, what will you do? Because you've been taught by MedCognito, you say that, oh, I remember. So I need to do what we call tonometry. I need to do tonometry. So I need to get my tono pen. So a tono pen is just like a simple pen, but it is used to measure the pressure in the eye. Always remember that the normal eye pressure is between 10 to 20 millimeters of mercury. 10 to 20 millimeters of mercury. In an acute presentation of acute angle closure glaucoma, you realize that the intraocular pressure goes above 60 millimeters of mercury. So almost 3 times the upper limit. Okay, so remember, what's the normal intraocular pressure? 10 to 20 millimeters of mercury. But in acute angle closure glaucoma, it can go as high as 60. And as I said, how do we do it? How do we diagnose it? By doing a tonometer, by applying a tonometer to measure it. Someone is asking, are there some bilateral presentation cases? In medicine, you can never say never. However, unilateral painful eye visual loss is the most common. 60-year-old and above female who is Asian or Indian American, who went to the movies with the son or daughter. As soon as the place became dark, the patient started complaining of severe eye pain, visual blurring. I can't see. I have frontal headache, nausea. I want to vomit. The sun touches the eye. The eye feels as hard as a rock. What do? Take the patient to the ER. What is the next best step? Get a tono pen to measure the pressure. What's the normal pressure in the eye? 10 to 20 millimeters of mercury. In acute angle closure glaucoma, what is the usual pressure? Above 60 millimeters of mercury to almost 80 millimeters of mercury. Now, you remember the way I was talking about all these presentations? Acute angle closure glaucoma can be confused with other presentations. It can be confused with other presentations like migraine headache. Because as part of acute angle closure glaucoma, there can be headaches as well. So people confuse it. And because it can also be a unilateral vision loss, people confuse it with temporal arthritis. Temporal arthritis, remember, the patient will come in with temporal eye pain, unilateral eye pain, and you may see the temporal artery may be bulging. You touch it. Okay. And it can also be confused with subarachnoid hemorrhage, sudden thunderclap headache. And then it could also be an intra-abdominal emergency. Why? Because acute angle closure glaucoma can also cause some form of abdominal pain and nausea. And it can also be confused with exacerbation of dementia, as well as Conjunctivitis. Why? Because if you remember the picture I showed you, you remember, you see the haziness and the red eye. So some people will say, oh, it's just conjunctivitis. It can also be confused with keratitis. And it can be confused with iritis. So an assignment I want to give you is, how am I going to differentiate between acute angle closure glaucoma from migraine headache, from temporal arteritis, okay, from subarachnoid hemorrhage, from intra-abdominal emergency, from conjunctivitis, from keratitis, from iritis. That is something you need to know, because in your board exam, you can be given a question stem and you should be able to differentiate between acute angle closure glaucoma and these other presentations. Okay? For example, acute angle closure glaucoma and maybe migraine headaches. You realize that migraine headache, the pupil is not fixed. It is not mid-dilated, right? That kind of thing. Okay. Now, let's differentiate between acute angle closure glaucoma from other differentials in a way we can remember. I've told you that's an assignment for you. So please make sure you deal with that and send me a message on +1 306 891 5649 +1 306 891 5649 +1 306 891 5649. Somebody just asked the simple question: can I watch this session later on YouTube? Yes, you can. Yes, you can. You can do that. So you just go to YouTube Live under MedCognito. It will be there waiting for you. Okay. As soon as the class is done, it will be there waiting for you. Okay, good. So how are you going to manage acute angle closure glaucoma? You know, if you understand the aqueous humor and the flow of the aqueous humor, it will help you to know what are the various places I need to touch in order to manage acute angle closure glaucoma. Okay, remember that we said that acute angle closure glaucoma, it could be as a result of excessive aqueous humor production. Number two, decreased aqueous humor drainage. So it can be that excessive aqueous humor is being produced even though it is draining normally, and because of that there's backlog of it. Or number two, it could be that normal aqueous humor is being produced, but it is not being drained quickly. Number three, it could be that there's a problem with the pathway of the aqueous humor drainage itself. So if you want to manage acute angle closure glaucoma, what you need to do is, number one, find a way to lower the intraocular pressure by blocking the production of aqueous humor. That's number one. Number two, you must find a way to facilitate the outflow of the aqueous humor. And number three, you must find a way to reduce the volume. So you have to attack acute angle closure glaucoma from various points: production, flow, and drainage. Please, I want to pause here to make sure that you are getting it. I want to pause here to make sure you are getting it. Are you getting it? Yes or no? Those on TikTok, are you getting it? Yes or no? Those on TikTok, are you getting it? Yes or no? Are you getting it? Yes or no? I'm saying hi to people on TikTok. Are you, and those on YouTube as well? Remember, acute angle closure glaucoma is a problem from excessive aqueous humor production, is a problem from the path of the aqueous humor, is a problem from the drainage. So that means that if I am managing it, first principles, if there's a problem with excessive production, then deal with it. Get a medication or get something which will deal with excessive production. If there's a problem with the path, then deal with that. And then if there's a problem with drainage, then deal with that as well. Thank you very much. So this doctor said production, flow, and drainage. Simple. Production, flow, and drainage. So this doctor says, please, can you explain again? Okay, let me take my time and go back. Let me take my time and go back. Let me take my time and go back. Okay. Now, if you can all see this picture, let me know. Just type yes, yes, yes. If you can see the picture. If you can see the picture, let me know. If you can see the picture, let me know. Okay? Because the doctor wants me to go back. Number one, remember that aqueous humor is produced from the ciliary region. Then it has to flow between the lens and the iris, and it has to come through the pupil, and it has to be drained here. Okay, so we are thinking about, okay, what can cause pressure to build up? Number one, if you have a normal drainage and a normal path, but excessive aqueous humor production, that can increase pressure. That's number one. Number two, you may be producing normal aqueous humor. You may also be draining, but the path may be blocked. Okay, the path may be blocked. And then the last point, you may be producing normal, the path may be normal, but the drainage may also have a problem. So if you are going to deal with how to manage acute angle closure glaucoma, what you need to do is to look at all these places. Where can the problem be coming from? It can be coming from excessive production. So you need to give a management for that. Number two, it can also be coming from the path. So you need to get a management for that. And it can also be coming from the drainage. So you need to be dealing with that as well. Okay? Now, so what then informs all these? So I saw somebody, somebody typed something here. Acetazolamide. You know, the person just typed it. Why are we giving acetazolamide? If you understand these three things, then you understand where acetazolamide comes in. So we have to give medications which can reduce the production of aqueous humor. Number two, we have to give medications which can reduce the volume of aqueous humor. And number three, we also have to give medications which can facilitate the flow. The flow. Okay? And if you get this, you've gotten it right. So when somebody comes to you with acute angle closure glaucoma, which medications can we give which will reduce or block the production of aqueous humor? Think about a topical beta blocker. So that is why we have timolol coming in. So you just keep applying timolol. Okay? And the timolol will help to block the production of aqueous humor. Please, do we all understand where we are getting to now? Why do we give timolol? Somebody will say, oh, just give timolol. Why? At MedCognito, we want to understand. Why are you giving timolol? Why do we have to give timolol? We give timolol because timolol can help to block the production of aqueous humor. Why are we giving apraclonidine? Because apraclonidine can also help to reduce or block the production of aqueous humor. Why are we giving acetazolamide? Why are we giving acetazolamide? Acetazolamide also helps to block the production of aqueous humor. So you see, we are dealing with production so that it doesn't produce more. Okay, so somebody is brought to you. Remember your timolol. Remember your apraclonidine. Remember your acetazolamide. So today, even if you are sleeping and somebody wakes you up, you should be able to explain to that particular person. Okay. Now, then another medication we can give is mannitol. Mannitol. Mannitol is given IV. Okay? IV, intravenous. You give it IV. And what mannitol will do is that it reduces the volume of the aqueous humor. So while timolol, apraclonidine, and acetazolamide are blocking the production of aqueous humor, mannitol is reducing the volume. And then while you are doing all these, you are checking the intraocular pressure. Please, who can remind me? What is the normal intraocular pressure? What is the normal intraocular pressure? Who can remind me? I need someone to remind me. What is the normal intraocular pressure? What's the normal intraocular pressure? Who can remind me? Normal intraocular pressure. Who can remind me? Normal intraocular pressure. Who can remind me? Normal intraocular pressure. Beautiful. 10 to 20 millimeters of mercury. And usually in a patient with acute angle-closure glaucoma, what level does the intraocular pressure get to? What level does the intraocular pressure get to? What level? What level? What level? What level? What level does the intraocular pressure get to? Normal intraocular pressure is 10 to 20 millimeters of mercury. Abnormal in acute angle-closure glaucoma is 60 to 80. Remind me, what are the risk factors? Risk factors, risk factors, risk factors, please tell me. Risk factors. Risk factors. I talked about 3 key risk factors. Please, what are they? Risk factors for acute angle-closure glaucoma. What are they? What are they? Female, beautiful. Female, beautiful. What else? What else? What else? What are the 3 risk factors? Acute angle-closure glaucoma. Risk factors, 3 of them. More than 60 years. Beautiful. Beautiful. And the last one. More than 60 years. Last one. Asian. Beautiful. Asian. So, how are we going to deal with acute angle-closure glaucoma? We're going to block the production of aqueous humor, right? We're going to reduce the volume, and we're also going to facilitate the outflow of aqueous humor. So, in your board exam, you should be able to tell if you are given a group of medications, okay, which medication am I going to give? Which medication am I not going to give? That kind of thing. Okay? Beautiful. Okay. So, as soon as you start giving your timolol and all those things, what is your next best step? Pick your phone and call an ophthalmologist. Next best step, pick the phone, call an ophthalmologist. You started your timolol, you measured your intraocular pressure and all those things. Now, while you are doing all that, pick your phone and call the ophthalmologist. Hello, sir. Please, I have a patient. The patient is a 65-year-old female. She was in a movie theater with her daughter. She started experiencing right eye pain. States that she has nausea. She wants to vomit. She has some abdominal pain. The eye is very hard. I use my tonopen. The intraocular pressure is about 75 millimeters of mercury. I've started applying timolol. I've even set an IV line. We're going to give her mannitol. We've tried apraclonidine. Sir, please, what should I do? The ophthalmologist will say, bring the patient. Oh yeah, bring the patient quickly. Bring the patient. And when you bring the patient, the ophthalmologist is going to do what we call laser iridectomy. Laser iridectomy. So, if you see the picture very well, looks like the ophthalmologist created something up there, right? Laser iridectomy. So remember the iris, right? The iris is the 2 things up there, one up, one down, and in between the iris is the pupil. So that the ophthalmologist has to create, some space in the iris so that the fluid can flow. That is the definitive treatment. Initial treatment, timolol, apraclonidine, acetazolamide, mannitol, right? Next best step after that, call ophthalmology. Definitive treatment, ophthalmologists will perform laser iridectomy. Laser iridectomy. So usually you can start with the timolol quickly, and because the mannitol will take time, because mannitol acts systemically, right? Mannitol will let you pee out more. So mannitol will take time. So start with timolol as soon as just start dropping it. But that goes beyond the scope of this class, right? I didn't want to go into when should you give this medication and all that. But timolol is usually the first medication you want to start with. Doctors, please, I have a question. Does it make sense? Does it make sense? Yes. So somebody's asking, what's the gold standard for diagnosis? It's tonometry. Tonometry. Use your tonometer. You're good to go. Doctors, please, does it make sense? Does it make sense so far? Okay. Good. Okay. So now that we've gone through this, now let's review some questions. Because as I said, as I said, I didn't want to start with questions because this is a very specific niche, right? And it's a very important topic as well. And I want to make sure that we go from there. Yeah. So Dr. Soros says in Toronto, nose laser iridectomy is the definitive treatment. Yes, that's what I'm saying. The definitive treatment is laser iridectomy. Okay, definitive treatment is laser iridectomy. That's the treatment. Okay. Yeah. So acute angle closure glaucoma has been made ridiculously simple. Now let's try some questions. But before we try the questions, I want you to remember that the new pass score for the MCQB1 is 439. 439. 439. 439. Okay? 439. The new pass score is 439. The lowest mark anyone can get is 300. So if you get 300, that means you got 0, literally. And the highest mark somebody can get is 600. Okay? And for us to say that you've gotten +1 standard deviation, that means that you scored 439 plus 30. So that is 469. So any mark above 469 is +1 standard deviation. To say the person scored above +2 standard deviation, that means the person scored 439 plus 60. So what's 439 plus 60? Let me just check it out for you here. 439 plus 60. 439 plus 60. 439 plus 60. So that means 499. Okay. So if you score 500 and above, that means you scored above +2 standard deviation. All right. Good. Now, so the results just came in, and these are some of the results of some of our students. 524 over 600. Ooh, this is powerful, right? 524 over 600. Okay. Other people scored 447, and he says, "Thank you so much, Dr. Brony. Thank you to all the other tutors, Dr. Nana, Dr. Prosper, Dr. Emmanuel, everyone in the team. I kept hearing their voices with me in that exam. This person scored 447. Okay, good. Another one scored 455. Another one said, I passed the QE10. I passed the whole Dr. Brony. This was my second attempt. The first one, I tried to do it on my own. The second attempt, I decided to join MedCognito. I joined for only 6 weeks before the exam, and I passed. Beautiful, beautiful, beautiful. So if anyone scores below 439, it's a fail. But the lowest mark you can get is 300. Okay, good. And then someone also says, yes, Dr. Brony, I've passed my MCQ and your instructions and YouTubes are valuable. So doctors, that's why we are doing what we do. Okay, yes. Someone also got 459. 459. You know, I'm not just showing you people who got more than 500. No, I'm just showing you that we have various people around the spectrum. Some scored 459, some scored 524, some scored 540 something. And doc, can you imagine? This is somebody's wall. This is somebody's wall. This is the wall. I say this shows dedication. So the person just got all these little sticky notes and put them on the wall. Why wouldn't this person pass the exam? Doctors, why wouldn't this doctor pass this exam? So you know what? We're about to solve some questions, but I just want to encourage you. In fact, the way people pass the exam, I'm so excited about it, right? So it says, hello, everyone. So somebody was advising, if you are here, that is, if you're in MedCognito, trust me, you are in the best place ever. MedCognito held our hands through it all, and we have made it. you make it to. Please be consistent with your class sessions. So doctors, that is what I want you to understand. Tonight, you have a class. Aside this class I'm having, tonight you have another class. Okay? Go through the portal. Go to the MedCognito portal. Please go to the portal and get exposed to as many questions. Buy the MCC questions. Do them. Medical Council of Canada questions. Do them. All right? Do them. Do the Medical Council of Canada questions. Get whichever question bank you want. ASQ bank, whatever you want. That's fine. Okay? Get them. Do them. Get them and do them so that, I don't know, my TikTok is giving me problem. Yeah. So do the question banks, whether it's UWorld or whatever you want to do. Do them. But look, what are them? We have a question bank in our program as well. And it has more than 4,000 questions. So you can do them as well. Okay? Do question banks. So UWorld is good. SQ Bank is good. Daily CDM is good. But more importantly, do the Medical Council of Canada's questions. And the Medical Council of Canada just released 55 free questions. If you don't have those questions, just send me a WhatsApp right now. I'll send you the link. Click on it and just do it. It's free. It's free. And they provide explanations. 55 free questions from Medical Council of Canada. Okay? So if you need those questions, just send me a message right now. +1 306 891 5649. +1 306 891 5649. And we'll send you the link. Just go there and do it. Okay? Someone says, I sincerely and wholeheartedly give all glory to God for this milestone, passing the MCQ1. To the entire MedCognito community, I say a big thank you. Your resources, support, the collective spirit made a difference every single day. And to Dr. Bruni, I'm deeply grateful. Your selfless dedication, encouragement, and guidance were truly instrumental in this journey. May God bless and reward you richly. To everyone still on the path, please don't give up. That's the other thing, doctors. Don't give up. You can't give up. You can't give up. Show up daily, even when it's hard. Ask questions. There's no shame in learning. Doctors, that is why we have this, open platform where we are all learning together. All right? Be consistent. Trust the process. And above all, stay positive. The journey can be tough, and you are tougher. Most importantly, pray hard. God truly makes a way when it seems impossible. Wishing every one of you success and breakthrough ahead. Let's keep lifting each other up. You've got this. Doctors, that's why I'm trying to create this community on TikTok, on Facebook, on YouTube. Click on the like button, subscribe, so that whenever we go live, you are there. You can contact me on my WhatsApp as well, +1 306 891 5649. All right? So, doctors, that is it. And one thing I also want you to remember is that the pass or fail result is determined not by comparing it to other candidates, but the Medical Council already has its own standard, right? And the pass and fail is built around that. Okay, so even if you want to get, a little feel of this whole exam and the experience people had, we had an open session on our YouTube channel. I'll drop the link in the comment section. And you can go there and review it as well. I'll drop a link in the comment section, and you can go there and review it. Okay, there's a link in our comment section. You can go there and review right now, please. And these are 4 different candidates who had 4 different marks, and they are sharing their experience. So just take your time and listen. Wonderful doctors from different parts of the world, right? Some from India, some from Ghana, West Africa, Nigeria, everywhere. Okay, so just click on it and just go in. So if you need help, we are here to support you. And someone says, I honestly can't thank you enough, sir. God bless you and the entire team. Amen. Okay, so doctors, if you need help with the QE1, reach out to me, +1 306 891 5649 on WhatsApp, and we'll guide you. +1 306 891 5649 on WhatsApp, and we'll guide you. Now let's solve some questions, and then we'll call it a day. First question. You have a 67-year-old woman who develops severe unilateral eye pain, blurred vision with halos, headache, and nausea after watching a 2-hour movie in a dark theater. Exam: red eye, cloudy cornea, mid-dilated, poorly reactive pupil. Eye feels very firm to palpation. What's the most likely diagnosis? This one, everybody should get it correct. Is it A, migraine, B, iritis, C, acute angle closure glaucoma, D, conjunctivitis, or E, keratitis? What's the correct answer? What's the correct answer? Drum roll. This one, everyone should get it correct. And the correct answer is C. Acute angle closure glaucoma. Acute angle closure glaucoma. That's the correct answer. Acute angle closure glaucoma. We learned that there's abrupt, painful red eye, cloudy cornea, fixed mid-dilated pupil, very hard. And the trigger is that maybe the patient was in a dark room, or the patient used an antihistamine, right? Or the patient snorted some cocaine. Or the patient even used like something like salbutamol, but that is rare. But the common things, remember, common things are common, right? And if common things are common, then you want to look for that person who was in a dark room. Okay, next question. Which patient is at highest risk? Remember, highest risk for acute angle closure glaucoma. Which patient is at highest risk? A, 25-year-old male of European ancestry. B, 40-year-old female of African ancestry. C, 72-year-old Asian female. D, 60-year-old indigenous male. And E, 55-year-old male of South Asian ancestry. So for you to be able to answer this, you must know the risk factors. The risk factors, we said age, more than 60 years. Number 2, female. Number 3, Asian or Native American. So if you look at all these, who has the greatest risk? It is C. That's 72-year-old Asian female. Okay, so risk factors include age more than 60, Asian or Native North American ancestry, and female sex. Doctors, you see, if you are prepared well for the board exam, you'll be able to kill it easily, right? Okay, good. By the way, doctors, please kindly click on our subscribe button. Kindly click on our subscribe button. Help us to grow. Help us to grow. Help us to grow. Currently, we are sitting at 3,080 subscribers. Please help us to move it to 3,200 subscribers. 3,200 subscribers. Let's do that right away. 3,200 subscribers. Okay, let's do that. 3,200 on YouTube. Let's go. Okay, next question. Which of the following is most likely to precipitate an acute angle closure glaucoma attack? Which of the following is most likely to precipitate an acute angle closure glaucoma attack? A, topical pilocarpine. B, over-the-counter antihistamine. C, morning sunlight exposure. D, IV beta blocker. And E, hyperventilation. Which of the following? Those on TikTok. Is it A? Is it B? Is it C? Is it D? Or is it E? Which of the following is most likely to precipitate an acute angle closure glaucoma attack? Is it A, topical pilocarpine, B, over-the-counter antihistamine, C, morning sunlight exposure, D, IV beta blocker, or E, hyperventilation? I see a lot of people going for B. And the correct answer is B. Okay? B. And what's the correct? What was in B? Over-the-counter antihistamine. Remember, we talked about it. Over-the-counter antihistamine. So let's review the triggers again. Over-the-counter antihistamine, that's a parasympatholytic agent. Sympathomimetics like pseudoephedrine and epinephrine. As well, if the patient is in a dim place, a dark place, if the patient is also angry, emotional stress, if the patient also uses intranasal cocaine and nebulized beta agonists, these are all triggers of acute angle closure glaucoma. Next question. In suspected acute angle closure glaucoma, which immediate bedside measurement best confirms the diagnosis? In suspected acute angle closure glaucoma, which immediate bedside measurement best confirms the diagnosis? A, central corneal thickness. B, visual evoked potential. C, intraocular pressure. D, visual field testing. And E, optical coherence tomography. Which immediate bedside measurement best confirms the diagnosis? A, central corneal thickness. B, visual evoked potential. C, intraocular pressure. D, visual field testing. And E, optical coherence tomography. What's the correct answer? What's the correct answer? Sure, tonometry. So that's a C. So here, I didn't say tonometry. I just said measuring the intraocular pressure. So diagnosis established by measuring intraocular pressure. Normal intraocular pressure is between 10 to 20 millimeters of mercury. And in an acute attack, the intraocular pressure can go above 60 to 80 millimeters of mercury. Now, next question. Which combination most strongly supports acute angle closure glaucoma? Which combination best or most strongly supports acute angle closure glaucoma? A, reactive miotic pupil with a clear cornea. B, fixed mid-position pupil with hazy cornea and rock-hard globe. C, purulent discharge with normal vision. D, focal fluorescent staining, the epithelial defect. And E, photophobia with consensual pain but clear cornea. What's the correct answer? And the correct answer is B. Characteristic physical findings are fixed mid-position pupil, a hazy or cloudy cornea, conjunctival injection, and rock-hard eye. Rock-hard eye. Rock-hard eye. Okay, next question. After initial medical therapy, what is the definitive treatment to prevent recurrence of acute angle closure glaucoma? After initial medical therapy, what is the definitive treatment to prevent recurrence of acute angle closure glaucoma? A, laser trabeculoplasty. B, peripheral iridoplasty. C, laser iridectomy. D, canaloplasty. And E, intravitreal anti-VEGF. After you've done your initial treatment, medical treatment, what is the definitive treatment? What's the correct answer? Is it A? Is it B? Is it C? Is it D? Is it E? And those on TikTok Live as well. Share it with your friends. Share the link. 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 And the correct answer is C. The answer is laser iridectomy. Laser iridectomy. Laser iridectomy. Next question. Once treatment to lower intraocular pressure is initiated, what's the next critical step? What's the next critical step? A. Discharge with next day optometry follow-up. B. Start high-dose steroids. C. Urgent ophthalmology consultation. D. Admit to neurology. And E. Observe in the ED for 24 hours. Once treatment to lower intraocular pressure is initiated, what is the next critical step? A. Discharge with next day optometry follow-up. B. Start high-dose steroids. C. Urgent ophthalmology consultation. D. Admit to neurology. And E. Observe in the emergency department for 24 hours. And the correct answer is consult ophthalmology right away. Consult ophthalmology right away. Next question. Next question. Next question. Which statement best reflects this, the definition of glaucoma? Which statement best defines the definition of glaucoma? A. Any condition with intraocular pressure more than 21 millimeters of mercury. B. An optic neuropathy not always associated with increased intraocular pressure. C. Elevated intraocular pressure with normal optic nerve. D. A disorder of aqueous production only. And E. Episcleral venous congestion. What's the correct answer? Is it A? Is it B? Is it C? Or is it D or E? So the answer is that, as you said, glaucoma is more of an optic neuropathy that may not always be associated with increase in intraocular pressure. Okay, so it's an optic neuropathy. So, doctors, how was the class today? I hope it was good. I hope it served you well, right? I hope it was good and I hope it served you well. So, this is my first ever TikTok live. So, those who are joining us on TikTok, I was sharing my PowerPoint slides. And if you want to see the PowerPoint slides, just go to our YouTube channel, okay? And you'll be able to see the PowerPoint slides. On the YouTube channel, it is spelled as MedCognito, MEDCOGNITO, MEDCOGNITO. And we will be here to guide you. And if you have any questions in your exam preparation, we are here to help. For those who are nurses, we run an NCLEX program. Those who need help with their CV preparation and interview preparation, especially for Canadian medical practice, we are here to help. For those who need help with therapeutic decision making, we are here to help.